Okay, we'll get started in just a moment. Can I please ask everybody to take their seats? Welcome, everyone. I'm delighted to be able to say good morning, good afternoon, good evening, and good morning for everybody who is here in person. We're really excited to be able to welcome all of you back here in person to the Graduate Institute on behalf of the Global Health Center and our colleagues at the United Nations Foundation. The last time we had this briefing in person was, of course, pre-pandemic. It was May of 2019, 3 years ago. We've had a number of these briefings online only since then, but I can see that there's a lot of appetite for us all to see each other and meet and be able to exchange in person for those of you who are here in person. And of course, to continue interacting with people around the world for those of you who are joining online today. It's the 8th year that the Global Health Center and the UN Foundation have been organizing this briefing in partnership, so I just want to take this brief opportunity to thank my colleagues from UNF, and Ambassador John Lang will tell you a little bit more about the history of this event in just a moment. But before diving in, I just wanted to make a couple quick opening remarks. And the first is regarding, of course, COVID measures. Some of you may not have recently been in Switzerland. In Switzerland, we no longer have any mask mandates, nor is vaccination status, nor do we need to verify vaccination status for public events. So that's the case for our event here today. But for anybody who would like to wear a mask, of course, that's very welcome. Please feel free to do so. We have masks and we have hand sanitizer available. But here at the Graduate Institute, we are governed by the Swiss policies. I also wanted to say that we had almost forgotten the very specific challenges of organizing an in-person event, which are in many ways much more complicated than turning on Zoom. But I'm really delighted, as I said, that our teams have worked very hard night and day to bring you all of us together, and looking forward to both the formal interaction here during the session and more informal interaction during the reception that will follow today. If you look at the program, you can see that, of course, COVID is not yet over. We are living in an era of pandemics, and pandemic preparedness and response remains very high on the political agenda, the center of media attention, and very high on the WHA agenda, as do other high-profile crises, such as, of course, the new monkeypox outbreak, the war in Ukraine, and many other headline-grabbing issues. But we also know that over the last 2.5 years, there are many critical health issues that have gone neglected and on which we have actually had serious setbacks. And I won't go through them all, but they, of course, include routine immunization for children, progress towards universal health coverage, action to address the many risk factors of the pandemic of non-communicable diseases, climate change and other environmental risks, and of course making sure that people are protected against sexual abuse and harassment in all health programs. So this is the reason why we organized the session today the way we did. We are trying to cover the broad range of topics on the agenda of the Assembly this week. We cannot, of course, cover every single one, but we think it's important that in an era of pandemics, we don't lose sight of the many other health issues that also require our attention. And my colleague, Ambassador Lang, will take you through the program in just a minute. The last comment I would like to make is that, as I think many of you here in the room know, there are no restrictions on the number of member state delegates at the Palais, but for non-state actors, those numbers are restricted to just 4. And as a result, many fewer people have either come to Geneva or many fewer people are able to go into the Palais. I wanted to invite you all to please consider the Graduate Institute your home away from home this week. If you'd like to meet up with people, just find a place to connect to Wi-Fi, etc. The library and the cafeteria, where we'll have the reception upstairs, and the lobbies are all open to the public. They're open to all of you. And for those of you who'd like a place to be and a place to meet each other during the week, please consider the Graduate Institute your home. So without further ado, let me invite Ambassador John Lang up to the podium to offer his welcoming remarks and walk you through the program.
Thank you very much, Swery, for that welcome, and welcome to everyone here. Good morning, good afternoon, good evening, depending upon whether you're here or watching on live stream. We're really delighted to be co-hosting this with the Graduate Institute's Global Health Center yet again. When Ilona Kickbush and I began this in 2015, the idea was to make for better informed discussions at the World Health Assembly. We really thought that too many people were coming here to Geneva to attend the World Health Assembly, either as delegates from member states or as delegates from non-state actors or as outside observers, the media, the general public, etc. And they didn't really know the current state of affairs for many of the issues that were going to be discussed, especially the controversial issues. And we created this program back then in 2015, held here in this auditorium for the purposes of having that better informed discussion at the World Health Assembly. We think we've succeeded over the years, and we're very pleased to be hosting this yet again. The last time, and the last couple of times we've done it, of course, it's been by Zoom, which has caused a lot of people to learn more about the World Health Assembly, but from a great distance. And it's just a delight to have everyone here in the room today. In the 3 hours from now, the 75th World Health Assembly will begin. The theme is Health for Peace, Peace for Health. And the agenda for today really is going to talk about the modalities of that assembly and how it will operate. We're also going to hear from senior experts on a variety of issues related to WHO's triple billion targets as we try to meet them in the midst of COVID-19. We'll talk about universal health coverage, and that's been so adversely affected by the pandemic, including the importance of some key aspects of universal health coverage, WHO's triple billion target, and that is strong health workforce and robust vaccine delivery systems. We also will talk about health emergencies. Last week, the co-chairs of the independent panel for pandemic preparedness and response, who issued that seminal report a year ago, issued a follow-up report. And that served as another call to action, even from its title, Transforming or Tinkering. Inaction lays the groundwork for another pandemic. It's very good reading if any of you have not seen it. And on May 4th, WHO published a white paper for consultation containing the Director General's proposal for strengthening the global architecture for health emergency preparedness, response, and resilience. It's known as HEPR, H-E-P-R. The WHO Regional Office for Africa is creating its own HEPR architecture at the regional and country level, and there will be much to discuss on that issue. We also will discuss the goal of better health and well-being. This pillar encompasses a wide range of important issues, and just a few of them include nutrition, alcohol use, obesity, road injuries, and outdoor air pollution. Finally, as the Assembly is expected to elect Dr. Tedros for a second 5-year term, we will talk about key governance issues, which is known as Pillar 4. Those include sustainable financing for the WHO budget, mainstreaming gender, equity, and human rights throughout WHO, and efforts to prevent sexual exploitation and abuse. So we do have a very full agenda for today. At this point, we will hear, hold on just 1 second. Is Steve here? Okay, at this point we will move to the first panel discussion for today, which is the panel for Pillar 1. If I could ask Gitinji Gitahi and Kate O'Brien and Jenny Ravello, please, to come to the stage. Gitinji Gitahi is the Global CEO for AMREF Health Africa. Earlier, he was Vice President and Regional Director for Africa for Smile Train International. Kate O'Brien is the WHO Director for Immunization, Vaccines, and Biologicals, and Technical Leader for the COVAX pillar of the Access to COVID Tools Accelerator, known as ACT-A. Please, you will all be able to see their full bios on the Graduate Institute's website. Jenny Lee Ravello is the senior reporter at DEVEX. If I could turn it over to Jenny, please.
Thank you so much, Ambassador Lang and Dr. Suri Moon, for the invitation to moderate this session. And welcome to Dr. Kate O'Brien and Dr. Gitinji Gitahi. Thank you so much for joining us today. Universal health coverage. So WHO defines it as all people having access to health services they need when and where they need them without financial hardship. That's the goal, but we know in reality, billions of people still struggle to access even the basic health services for a number of reasons. One of them includes lack of healthcare workers to provide and deliver those health services, including immunizations, particularly in the rural parts of the country. And this has been exacerbated by COVID. And we know by the numbers given by WHO last October, between 80,000 and 180,000 health and care workers could have died from COVID from the period between January 2020 to May 2021. Now, WHO in 2019 set a goal of having 1 billion more people benefiting from UHC by 2023, but in its latest results report, published last week, it's clear this won't be reached. As many as an estimated 840 million people still don't have access to universal health coverage, and WHO is looking forward to having that goal extended in 2025. Now, the question is, what can be done to make that a reality? I want to go first to Dr. Gitahi. And just, because this week, one of the agenda at the WHA is human resources for health. Now, we know there's been a lot of talk, especially in the past 2 years, on just how essential health and care workers are and the need to invest in them. But is this all talk? I mean, what's the reality on the ground, Dr. Gitahi?
I hope it's on. I hope you can. Yeah, thank you very much. First, I'm happy to know that you're all as tall as you looked on Zoom, and really good to see you. It's been very many years of virtual connection, so I'm glad to see all of you here. The challenges that are raised in this conversation have to do with resources and governance. First, to look at universal health coverage, then I'll come into the health workforce because they are connected, is that for you to achieve universal health coverage, we are saying that you need 100% of the people receiving the services they need. So you're talking about equity, but you're also talking about service delivery. And then you're talking about equitable financing. So they are all related. Now, some quick statistics. For my continent in Africa, the average per capita expenditure on health, is about $70 to $80 per capita. Now, in OECD, that would be about $4,000. Okay. Now, if you take that $80 and you divide it, who pays for what? The government pays for about 30% of that only. And then the rest of it is aid, which is smaller, maybe 20%, and the balance is people out of pocket. Now, when you look at that out of pocket, or even if you look at the government side itself, the question is, how is it spent and where is it spent? Then brings the question of, can we afford the health workers we need based on that amount of money? And the answer is that no, we cannot. Unless we refocus the health workers from the current way we look at health workers, starting with physicians going down, to actually looking at health workers from a point of skills mix that are needed, that are context specific, and also focusing the health workers to primary health care. Because right now we have a huge focus on tertiary and secondary care. In the continent, largely in most countries, health workers take 70% of the $30 the government contributes. And therefore, even if you are to increase that, then where do you get money for drugs, for commodities, for other areas of health financing? So the challenge that we are having with health workers is not even a challenge of production in many countries. I know that South Sudan and some other fragile states have a challenge of production. In many other countries, it's a challenge of absorption, where actually health workers are being trained, and they are needed for delivery of universal health coverage, but the financing available is not, it's not enough to absorb the health workers who are needed. And that cuts across many of the countries. So recently, the Africa Union, through the COVID-19 Commission of President Cyril Ramaphosa, has picked up this issue. And it's a global issue. WHO has picked it up. We have many conversations this week. And through that, there was the creation, through the Africa Union Summit in February, of the Africa Union Health Workforce Task Team, which is going to be established to do country by country compacts about how to develop health workers that are fit for purpose, not adopting global standards, fit for purpose for each country, for each context, starting with community health workers and building up. So that this is going on. There'll be conversations this week. Tomorrow in the morning, actually, AMREF is hosting a health workforce meeting that's going to be attended by President Kenyatta in the morning at 7:30 and Intercontinental. You're welcome. And the question is, what are we going to do with such little money? We have to actually repurpose and start to think about where is the health worker, which health worker, and where are they needed most, because you don't have money to achieve all the needs of health work for the health system.
Yeah, that's a follow-up question. So where will the money come from? Like, these are all good initiatives, but at the end of the day, you need the financing.
There is, let me first say that,
Are we expecting it coming from G7 donors, G20 donors?
we have to put the centrality of domestic resources in this conversation, that the government themselves have to actually first put the money, okay? The money that we have right now, the question that's being asked, and this is why, because it's so little, we do not expect that to drive the need of health workforce in Africa, that donors will meet the gap. We don't expect that. Even right now, actually donors are both a good and a bad thing. Because when they are actually investing in healthcare, in health workforce, a lot of them are investing in very vertical ways and saying we are going to pay for health workers for HIV and TB. Now that doesn't necessarily address maternal and child health, okay? Doesn't address NCDs. NCDs, for example, no one is funding any health workforce for NCDs. So that's number one. Number two is that the approach we have on health workforce by organized development aid and foundation and everything else is a capacity building approach. So if you look at reports on health workforce utilization in Africa, you have 65% absenteeism of doctors and 40% absenteeism of nurses. And that absenteeism is not people running away from work. It's people going for trainings, for workshops. If there are doctors here from Africa, they can confirm, and nurses, that people are constantly in this meeting. So one is, we have little money, but how do we increase the efficiency of that money? By increasing health workforce availability, by integrating health workforce at primary healthcare level. So first is increasing efficiency of what we have, even before we go and say now, donors need to finance this, because it's a highly domestic resources-driven agenda. Donors are financing commodities, largely. They're not financing human resources, because they see that as a dead-end investment. So it's a bit of complex, and that's why Africa is saying we need to address this ourselves, and we have to look at how do we optimize what we have to get more from the same health worker, and also to get the right mix for the context.
you've mentioned about the important work that country or governments themselves actually play in all of this, right? And I want to talk to Dr. Kate O'Brien. For those of you who've been following the WHO press briefings, I'm sure you're familiar with Dr. O'Brien already. Um, we have challenges right now with COVID vaccines. We know that a lot of people in low-income countries still don't have not received at least one dose, and we also have problems with childhood immunizations. Um, Dr. O'Brien, can you just talk us talk us through about the the challenges at the moment and how can we address them?
Well, I think just jumping off from the discussion around healthcare workers, this is one of the most central issues with immunization. Just to give some context for the scale with which the world needed to advance immunization, on a year before COVID happened, about 4 to 5 billion doses of vaccine were given for all of the antigens that we have everywhere in the world. And you'll remember that now we're at 11.7 billion doses of just COVID vaccine itself. Now, who actually gave all those vaccines? So the healthcare worker issue is a really critical one, and I really appreciate the points that you made around tailoring exactly what functions are needed and at what level they're needed. And I think we've seen countries innovate around health workers for immunization, using many other functions in the health system or outside the health system, actually, to scale really quickly on COVID-19 vaccination. But beyond healthcare workers, and I do want to also comment on the protection of healthcare workers with vaccination. And I think with this pandemic, it's one of the first times that we've really seen this absolutely central focus on health workers as the highest priority functions to protect using immunizations. And yet, great advance of healthcare worker vaccination. About 77% of the world's healthcare workers are now vaccinated, but that's really unequally distributed across income strata. So in low-income countries, still below 40% of healthcare workers vaccinated. And lots of issues around why that's the case. Of course, in 2021, this was absolutely predominantly about severe supply constraints and an inequitable distribution of the world's vaccines. Beyond healthcare workers, though, I think we do have to address the pay of healthcare workers as well. So having healthcare workers who are there but are not paid is a huge impediment for their motivation, frankly, just their ability to do their job. But beyond healthcare workers, there are so many dimensions of the health system that are part of primary health care, that are part of universal health coverage, where the immunization program needs to make advances. Now, immunization is the program that has the furthest reach and the broadest implementation of any program that we have. And so it's a really critical foundation for other services. And we've had in the past 2 years a slipping back. We've lost about a decade of progress just in the past 2 years. Now, that's not to say that it's going to take a decade to recover, but it does mean that as the world heads into very difficult economic times as a result of the pandemic and other issues, every program is going to be stretched. And this rapid recovery of the immunization program is really critical, not only for the life-saving vaccines for children, but life-saving vaccines across the life course. Not only COVID-19, vaccines for pregnant women, for healthcare workers. We now have monkeypox. We'll see what happens with that. And certainly the anticipation and readiness, preparedness for pandemics of the future. We don't know when and if they will happen, but I think you can't have lived through these past 2 years and not see immunization programs at the heart as a crucial part of the preparedness and readiness and response to critical emergencies and pandemics.
But how can we, increase immunizations now and increase even COVID vaccinations? I mean, ACTA just mentioned recently that demand for COVID vaccines have slowed down. And can you also talk about how misinformation and disinformation plays in all of this, and what's the WHO game plan?
Yeah, so what needs to happen now on the immunization program, and then I'll speak specifically about COVID sort of a little bit separately. But the entire focus and urgency is on the agenda on what are referred to as zero-dose children. Zero-dose children are those kids who receive 0 doses of vaccine through the routine immunization program. They may get a dose through a campaign or a special program, but through the routine program, they're not serviced at all. And these kids, there are about 13 million of them before the pandemic started, and the target for the decade was to cut that in half, down to 7 million kids who were 0 dose. Unfortunately, we've gone backwards. We're at 17 million kids instead of 13 to 14 million who are 0 dose children. And these kids are really special because they're not a random group of children. They are sitting in families and communities that are effectively 0 dose for most other services. Their mothers are not getting prenatal care, there are not educational services, there's not sanitation, there isn't nutritional assistance. So these are really very important special communities across the whole of primary health care. And as we figure out where they are, and we have great data now, we have great tools to be able to find them, lots of digital tools, GIS technologies, a lot of mechanisms to identify who is actually left out. It's much easier to measure who's left in. It's much harder to figure out who's left out. So this is really the focus, is being very targeted, country by country, subnational area by subnational area, district by district, is finding and serving those kids who are completely left out. It's also about catching up the children who have missed vaccines. If you're a 0-dose child, you become a 0-dose 5-year-old and a 0-dose 7-year-old. And so it's really important, especially for the children who have missed their vaccines in these past 2 years. They become sources of vulnerability. They become the part of the community that remains completely non-immune to measles, to yellow fever, to other outbreak-prone diseases. So those are some of the critical things that are needed right now, is very tailored micro-planning and addressing those 0-dose children, of course for polio as well. And we've seen now 3 cases of wild polio in the Africa region and the African continent, which is a polio-free continent. This is obviously of highest priority, highest urgency to address that. On the issue of demand and vaccine hesitancy, WHO really highlighted vaccine hesitancy and vaccine confidence as an issue in 2019. And it is an important issue, and we've seen an enormous outflowing of misinformation and disinformation and overflow of information, the term infodemic, this overflow of information. And I think it's something that we know is important. People are inundated with messages. They're inundated through the internet and all means of social media with information. It's extremely difficult for people to distill and distinguish credible information from non-credible information. But I don't think that we should over-index on this. And I want to just make the point that demand is far greater than the issue of vaccine hesitancy or information and disinformation. I sort of divide demand into those people who are vaccine motivated. That's a relatively small group, actually. There are people who are vaccine hesitant or anti-vax. That is a very small group. And there's a very big group in the middle, which I term vaccine indifferent. They're neither opposed to vaccinations, neither are they highly motivated to move heaven and earth to get vaccines. And so demand is really about making vaccines so easy to get, so accessible, such high quality, in the place, at the time, in the way that mothers especially can access vaccines. So demand is very much about accessibility of vaccines, quality of the program, and political leadership. And that political leadership is really at the community level. It's really about whoever those leadership voices are. They're often religious leaders, they're community leaders that may not be religious leaders, but it's really about that norm setting from within the community around the value of vaccines and breaking down every barrier that there is that would otherwise make it difficult for a very busy mother or a very busy father to actually access vaccines for themselves and for their family?
I want to talk about financing because I imagine, at the end of the day, we still need financing to move all of those different parts together. Um, there's now a talk about a global health security fund. Um, and my question is, how much of that talk, how much of that money, and the independent panel is proposing $10 billion a year. But how much of that money actually goes to health system strengthening, to actually pushing for vaccinations, to actually addressing the needs of healthcare workers? Maybe Dr. Kitahi, you can start.
Well, I'll let Kate, I'll let Kate talk about the Global Health Security Fund because, well, the global health architecture has many positive things for it going, but has also a lot of failures. And I think we need to not be too optimistic about some of these things, that we need to actually be dependent a lot more on what exists and integrating what exists. And actually, we should be building on what exists. We should be building on WHO. We should be building on the structures that exist instead of creating new ones. Because when you create new ones, I don't know how many of you here remember, and if there's a World Bank person, forgive me, the Pandemic Emergency Response Fund, PAF, of the World Bank, that did not move a finger when COVID-19 came. And yet it was set up, it was launched. So we have to be very careful about all these new initiatives and how much of that actually goes into changing things on the ground. So I would let Kate comment on this particular Global Health Security Fund and how much, in terms of its structure, might reach the bottom. But I want to reflect on an issue of that Kate has talked about on how to optimize the resources that are existing. Now, if you look at COVID-19 vaccination, we know, and I 100% agree, that actually the people willing or not opposed to receiving vaccine in my continent, based on 2 or 3 surveys that I've seen, is up to 75%. Up to 75%. But how many people are vaccinated? In the range of 20%, okay? What is the gap? The gap is actually failed access. It's actually access. And when you look at the health worker issue to connect it to this access, the entire pharmacy of pharmacists, pharmaceutical technologists, health workers are not part of the vaccination health workforce. Can you imagine? In Europe and North America, it is very different in many countries. But in Africa, we have a huge cadre of health workforce that's not participating because the policies don't allow them to. The policies don't allow a pharmacist to inject. So that's why I'm saying that actually the resources we have, if we want to actually start working on policy modeling and looking at the context, task shifting or task sharing, we can actually already start to gain so much more. And that's what the conversation is across the continent. Integration of health workforce from verticalization to integration so that you gain more from health workers. You have health workers who wake up and go to a HIV clinic funded by Global Fund and then go home. That's their work, is to manage that. What can they do if you integrated all these community communities and everything else? How can we do if we reviewed the existing cadre and said, how do you task shift or task share? How do you review the policy environment to enable more people so that people can get vaccinated? You won't imagine that in many countries in Africa, vaccination centers for COVID open at 10 because nurses have to do all the other things in the morning, and they close at 4 because they have to finish all the data entry and send it out. Then Saturday and Sunday, they're not open. So how is this person who is actually ready to be vaccinated going to be vaccinated if they're not convenient around their lifestyle? But in terms of this financing, the question really we need to ask ourselves is how the money flows and what are the incentives for the use of the money on the ground. If the money, for example, as talked about the World Bank, is going to be structured around private sector, then you have to ask what are the actual incentives? Are they social incentives or are they capital incentives? So I think there is a structure. I would like to hear a little more from Kate about how the Global Health Security Fund intends to actually impact on the ground. Kate.
Do you have any insights, Dr. O'Brien?
Well, I think we're seeing some of the early insights. First of all, everybody recognizes that the health system First of all, there's only one health system, and I want us, all to just really ground on that. There's one health system. There's some functions in the health system that are more or less critical for emergency settings, but there aren't two health systems. There's not a health system for emergencies and then a health system for non-emergencies. And part of the issue about readying for future emergencies is recognizing what those functions are that are so critical for emergencies and assuring that they are well capacitated, they are well built, they're well-oiled machines. But you can only do that if they're used on a day in and day out basis. We don't have any machinery in our own lives that if you leave it sitting for months, years, that you pull it off the shelf when you most need it, you discover that it's corroded and it doesn't function anymore. So really this is about having the health system exercising those functions, exercising those parts of the health system. So that means surveillance. It means immunization. It means case detection. It means demand. It means community engagement. I mean, there are many parts that are absolutely central and critical for the response to an emergency. And it really means trust. And I think we can't really be talking about any of this unless we address the issue of trust, which has been deeply eroded in virtually every country in the past years, not specifically around the COVID pandemic, but around many issues. We're in a real swing, I think, of cultures and belief in government and understanding of the way our governments serve the communities in which they are intended to serve. So those are things that we will never be ready for the next pandemic or the next emergency unless we're very serious about those things. And that means that governments have to deliver. They have to deliver what they were asked to deliver and what they're capacitated to deliver for people. And this is really, for me, where civil society is so critical, is holding governments accountable. Governments are ultimately only made up of the people in the country, so they are the same citizens. And it really is about civil society and other mechanisms. Of course, WHA is one mechanism where ministers come and there are reporting on the performance of their programs and of their countries, which are visible to them and to the rest of the world. So these are accountability mechanisms that I think are really important. And then I would like to just also address the issue of gender. And I don't think we can actually be talking about any of this unless we have gender as a front and center issue. And I think using the immunization program as one example of gender is a great example, but it shows up all over the place. These zero-dose kids, you cannot solve the problem of zero-dose children unless you address the issue of gender. It is predominantly women who are accessing services, and gender is not only about women, it's about the role of men, the role of women in society, and it's about each of their abilities to do what's necessary to actually access those services. And it comes through on healthcare workers also, very significant gender issues. We see in the polio program in some countries where the critical nature of who is delivering services on a door-to-door basis and whether or not that can be successful.
Exactly. And I think it's gender and intersectionality, because we are coming to the end. I don't know how many of you saw a remark by the Louisiana senator. I don't know how many of you saw the remark by the Louisiana senator, Bill Cassidy, 2 days ago said, well, Louisiana is doing very well on maternal mortality if you remove black women from the data. So it's also about intersectionality, that is, the women who are actually affected are also the ones who are in poor communities there. So it's a lot to unpack around gender and intersectionality as well. But thank you very much.
Thank you so much, Dr. O'Brien, Dr. Gitahi, and back to Ambassador Lang.
If I could ask the speakers for Pillar 2 to please come forward. Thank you very much for that very informative discussion on Pillar 1 billion more people benefiting from universal health coverage. A lot of different aspects of that. We very much appreciate it. At this point, we're going to talk about Pillar 2 under the WHO General Program of Work 13. 1 billion people better protected from health emergencies. Now, of course, for many of us, the last 2.5 years has been one big health emergency. as we coped with COVID-19 and still are coping with COVID-19. And much has been discussed about this, including at forums that we've held jointly, the UN Foundation and the Global Health Center at the Graduate Institute. For today's discussion, we'll hear from Abdul Salam Gay, the Regional Emergency Director for Africa at WHO in AFRO, the Regional Office for Africa. Earlier, he worked for 10 years at the U.S. Centers for Disease Control and Prevention. And we'll also hear from Agnes Sukat, Head of the Division of Health and Social Protection at Agence Française de Développement. And she formerly was the WHO Director for Health Systems, Governance, and Financing. Our moderator is Preeti Patnaik, the founding editor of Geneva Health Files. Preeti?
Good afternoon, everyone. Thanks so much for joining. Thanks for the invitation, Suri and Ambassador Lange. It's great to be back here. The Graduate Institute is my alma mater. I look forward to a great discussion with our panelists. Before we get to the discussion, I'll just spend a minute on the context of the white paper that the Assembly is going to consider in the coming week. So our discussion is located on the targets to ensure 1 billion more people protected from health emergencies. This objective predates the pandemic. So it's interesting to review WHO's new framework on strengthening the global architecture for health emergencies, preparedness, response, and resilience. And as was indicated earlier in the discussion, this acronym is being used already. It's HEPR, or the HEPR framework. So at the Assembly, member states are going to consider a set of 10 proposals that DG Tedros has put together. And the genesis of this was at the Executive Board meeting in January 2022, member states asked WHO to articulate its vision on what kind of role should WHO play in the evolving global health architecture. So this paper is in response to that. And these 10 proposals straddle the areas of governance, systems, and financing. And some of the proposals include a global health emergency council, a World Health Assembly Committee for Emergencies, and amendments to the IHR, scaling up of the Universal Health Preparedness Reviews, among other proposals, and also kind of endorses the Financial Intermediary Fund at the World Bank. We will be basing our discussion on a document that was uploaded on WHO's website on the 4th of May. We are yet to see the final document that will be considered this week. So essentially what we want to know from our panelists is how do we understand these proposals? Maybe you can help us unpack. My first question will go to Mr. Gay. Given your rich expertise at the regional level, how do you see the centrality of the role of WHO vis-a-vis regional organizations such as, say, the Africa CDC? How do you see this coming together? If WHO is at the center, how do you see the role and the space for regional organizations?
Thank you very much. The World Health Organization, as said, there is a secretariat that all we are part of the secretariat, but also the member state. So when we talk about the regional organization, WHO also is a regional organization, because when you go to Africa, the director is elected by the member state, and also we have regional committees that are asking WHO what to do in a regular basis. What would be the role of Africa CDC? In Africa, for example, we have so many issues in health system, in health emergency, and others, that we need several Africa CDC in order to tackle those issues. So what we need is just to have a coordination mechanism where what needs to be done will be clarified, and also people will work together in a complementary manner in order to push. Recently, I went to Addis Ababa and sat down with my colleague with Africa CDC. For a week, we went to the details. what are you planning to do for the next 5 years for the population of Africa in order to save life and reduce pain? And we said what we want to do, and they said also what they want to do. When we checked, it was so interesting, and we could complement each other at any point, and there is a place for additional organization to work together.
But do you think there needs to, better streamlining between WHO with the regional architecture, as it were?
The WHO and the regional architecture, that's where I say better streamline. When you write it well, it is at the field that how the collaboration will be determined. And how we can collaborate is for the technician to sit together and know exactly what the other is doing and where we can really put our force together and succeed.
Thanks so much. We'll get into greater detail into that just in a minute. Agnes, on the financing side, things are moving very quickly. The G20 has endorsed the Financial Intermediary Fund, but we are also aware that there's a huge compressed fiscal space, as it were, for countries. And this fund is supposed to have at least $10.5 billion in external financing for LMICs. What role do you see, can this fund actually fix some of the intractable problems of financing for health emergencies?
Absolutely. I think, absolutely. And I think this is, for now, 2 years after the pandemic of COVID-19 started, this is the first element of reform that we can actually really grasp, in the sense that for the first time we have a fund that is designed to incentivize countries to invest in global public goods, in global commons, at country level, at regional level, which was the failure of pre-COVID preparedness. The COVID-19, I mean, in many ways, has really shed a brutal light on our collective failure in global health of the past 20 years, in investing in the fundamentals, in investing in surveillance institutions, in investing in regulation, market regulation institutions, in investing in public health programs such as One Health, animal health, environmental health. We have not invested in the public health institutions that are needed for us to get ready for the future risks that are linked to environmental challenges. Whether this risk is pandemic, whether it is environmental, it is chemical, it is physical, there are biodiversity loss, antibiotic resistance, antimicrobial resistance. All of this will require a shift in paradigm in public health, and we need a different type of institutions. And when Gitinji in the previous session mentioned the failure of the PEF at the World Bank, it is a very, very different type of fund in this case. The lessons have been learned. The PEF was an insurance mechanism and was using a market-based approach. And indeed, it's been a failure. I think we need to all recognize it. When COVID struck, countries got very little money, and they had to fulfill a lot of conditionalities to access this money, but mostly it was a very little amount, while in fact shareholders who had invested in the PEF got paid and got benefits. So it was a failure, but the new FIF is actually responding much more to what global financing of public goods should be, which should be public financing. It should be managed by an institution that has access to other sources of funding, that that we've seen in during the COVID-19 crisis is that you cannot just rely on a small fund at global level with a couple of tens of millions. What you need is to access deep pockets and access lending, access guarantees, access credit lines, and it's been the success. I mean, financing has been the success of the COVID-19 response, the other success being science and these networks of scientists, these horizontal networks of scientists exchanging in real time and publishing preprints and producing knowledge very quickly. So these two successes, we need to build on them, and we need to address the failures, and the failures are much more in the global health policy arena, global health policy and politics, and also in the access to products, the purchasing, where we see that having a centralized mechanism at global level that is responsible for identifying the needs, purchasing, raising funding, allocating, it just doesn't work. It's just too centralized. So we really need to build on what we've learned of how the world works in the 21st century, which is much more multipolar. The geopolitics are very different today from what they were in 1949. In 1949, the WHO was created in a colonial world, where a lot of decisions indeed were taken by a few countries at global level through a UN mechanism. That's no longer true, and it shouldn't be true. And we've seen it didn't work for a region like Africa. So there is really this need to build these institutions at national and regional level, and there should be much more funding that is channeled to public health institutions at country level than there should be at global level.
Thank you. I think some of us could argue that WHO is still sort of funded by a select group of countries. So on the FIF, actually, just to put the numbers in perspective, the European Commission and the US have announced contributions of up to nearly $500 million each. And what member states will approve this week is an increase in assist contributions of 1.2 billion over 6 to 8 years, that too with strings attached, just to keep the numbers in perspective. So on the maybe you would want to come in here, Salam, on the what financing means at the regional level, and also people are skeptical about the World Bank, what it means for countries accruing debt. So we'll have to see the details.
Yeah, it's really very interesting when I heard about all the $1 billion that are coming into health in general and also in health emergencies. As a field person, even when I was in US CDC, I was the field person going on all emergencies in Africa. We have 3 levels where we need funding. The first is the initial investment, where we need to train people to buy the equipment, and like cars, and also to build sometimes the centers like the emergency operation centers. Those initial investment, often it is really interesting. When you ask for it, you get it. World Bank is looking for it, and many bilateral are looking for it. And the second investment in health emergency is how to maintain those people you train, or the building you built, or the car you bought. Almost very nobody. And often, that's where it is important, because I just wonder every time how you can build something, and after you come back, it is not working, but you build other things again. And the third part of funding, where it is, again, the most important, small funding, is when you are going to the initial response. There is a signal that is declared by event-based surveillance, and we need to go to confirm if it is a signal. If we confirm it very early, this outbreak can be stopped from being an epidemic and stopped from being a pandemic. You need a little bit like $2,000, $3,000. I was the program director for health security in DR Congo, which is often the epicenter of many outbreaks. Most of the time, I was taking my own money to send people to do those investigations. Or even if I was able to buy a ticket and send them to do the investigation, if I am with them, often I will be paying them the meal to eat because there is no system. While at the same time, for the World Bank and other partners, there is over $1 billion available in DR Congo to respond to emergencies. But there is no mechanism to fund those small money. There is some rare organizations that start to understand. I'm not doing the marketing of anyone, but it is a fact, like Resolve to Save Life would give $10,000 that are more useful than the $1 million that are available. You go to the last one, which is the money to pay for the operations. That one also is very sexy. Everybody want to pay for it. You often will not have, is to scale the intervention. You will even wonder, at some point in big intervention, we need it, but we were spending over $1 million a day, and it was available. While where we need it and we could stop it, we just needed $5,000, $2,000, it was not available.
There's, one of the emphasis of the HEPA framework is actually strengthening systems. And by that, we mean actions relating to surveillance, community engagement, and emergency operations. It's great that you bring in this sort of granular picture from the field. So how are these kind of activities progressing right now? As we're talking about an evolving global health architecture, but things have they changed on the ground, and should we be optimistic about it?
I am optimistic always because I think if I was not optimistic, I would not be doing this job. But when we say global health emergency architecture, we should be clear that it is only one system, health system, as said just my friend. The global health emergency, we can consider it like while we are developing the global health system, which is the most important, we need to save life, because emergencies are happening. That's why we are talking very quickly about the global health emergency architecture. We need also to consider the global health emergency architecture as the protector of the health system. If you invest on the global health emergency architecture, at least the health system will be more resilient and continue to work and bounce back when we have an emergency. And in the field in Africa, going from all our countries receive a joint external evaluation. We have intra-action review, after-action review, and a lot of information that we'll learn from the COVID, and also oriented by our Director General in the Global Health Architecture and all the information. We have developed the architecture that works in Africa. The first, it is based on workforce. We do believe that for health emergency intervention, we don't need thousands of people. We thought about around 50 people per country that are going to be multidisciplinary, multisectorial, are trained and given the capacity to respond, can prevent a lot of epidemic and maybe pandemic. The second is about readiness coordination, where through the National Public Health Institute, the Emergency Operations Center will support countries to develop their capacity to coordinate instead of others coming to coordinate. The third one is related to operation support and logistics. During the last pandemic, the pandemic still ongoing, the COVID one, we did not have masks, we did not have respirator, we did not have vaccine, and probably if the treatment comes, we will not have enough. It's not because there is no money. There's almost not a very strong support in terms of supply chain in our ministries of health. I went to several ministries of health. I asked them, who is the head of your supply chain? Often the minister can't tell me the name because often it doesn't exist. The supply chain in emergency. And there is also the community organization. And the most important that I reserve is the surveillance. The surveillance, where the integrated disease surveillance and response. That was going on since 1998, and it worked. In Africa, mostly, according to the study we have, it takes around 8 days between the onset of the first symptom and the detection. So it is pretty good. There is a lot of problem that we can learn from COVID and improve it, like the use of technology, better use of technology, but also the use of some new knowledge like bioinformatics, genomic surveillance, and all those we have packaged it into a flagship initiative that have 3 arms. One is about preparedness, one is about detection, and another one is the response. And we are working with our friend from Africa CDC, hand to hand, very complementary to implement those flagship initiatives in Africa.
Thanks so much for that. Just zooming out and coming back to Geneva in some sense, you know, the HEPR concept actually strives to bring some sort of coherence to a fragmenting space. So to talk about the elephant in the room, which is that you have these parallel processes of, you know, amendments to the IHRs, you know, that have started, and negotiations for a pandemic accord. You know, the idea is that both of these will progress together and could bring a holistic package of reforms. But do you think that these two streams can be greater than the sum of the parts? You know, what will be the picture, let's say, 2 years from now?
Well, I think the answer is very clear, very likely not. If we look at the recent call from Ellen Clark and Ellen Sirleaf, and transforming or tinkering, I think here we're clearly in the tinkering space. I mean, some would say it's just moving chairs on the Titanic. No, that's not reform, right? That's not reform. It's adjusting what is there, what has not worked. The IHR has been a very poor predictor of the preparedness, the real preparedness and the response. Modifying it is a technocratic response, but it's not a response to the fundamental governance problems around the issue of global emergencies. And here I think, as I said, the elephant in the room is the role of WHO. WHO is a political organization. It's a World Health Assembly of ministers who are politicians, and the WHO leadership are elected officials, and they appoint the senior members of the WHO, the senior management. So it's a political organization. This is what it is. It's been designed that way. It is functioning that way. It is funded that way. The issue is the separation of this political function with the science function. And that's what we've seen has failed during the pandemic. This is why we've seen the success of emerging networks of scientists who have actually really provided the knowledge, provided the evidence, have led a very vibrant conversation that frankly has really saved a lot of people. And if we move forward, we need to address that governance problem. And we've seen it in every country. The political tinkering, the political influencing of science is a problem. So we need to create separate space in which politics and science are separated with a firewall. And we've seen that happening. We've seen that happening in many countries. We've seen it happening in China, in India, in the United States. That's not, there is no question that it's happening everywhere. The question is the scientists and the technical guidance should be independent, and it should be under a scientific governance. And this is the recommendation in 2 Lancet articles on the reform of WHO, one by Anthony Costello, who is a former director of WHO, and one by Olivier Ney and Françoise Barré-Senoussi, who is a Nobel Prize who discovered the HIV virus. And both are saying that this is really the reform. It's the only reform that matters, is that separation between the political function of WHO and the scientific guidance. The scientific guidance should not be under political control, and this current proposal doesn't address that.
So you're suggesting neither the IHR amendments process or a potential pandemic accord can sufficiently address this?
It's not going to change it. It's just putting more politics, which are already there. The technical guidance needs to be separated. This is what the government of France has done with quite some success, is to have a scientific committee that provides its recommendation, and the recommendations are actually presented to the political council who makes the policy decision. And it is a basic principle of governance, right? It's a principle of governance that the science space needs to be autonomous, so the US CDC needs to have more autonomy in terms of providing scientific guidance. And it actually goes back to the discussion of the respective role of WHO and the Africa CDC, or CDCs in Africa. Is WHO is a political organization, it should work on the policy, but all the science functions, the statistics functions need to move to the CDCs so that both are independent and we have a clear discussion that is scientific, that is not played with by massive political interest.
I mean, that's interesting because there are concerns also about WHO's normative functions being too narrowly funded, and that is of concern to several member states. Just the last word, I don't know, we'll probably have to wrap up. Do you want to comment, Salam, on finally, you know, what should member states and other stakeholders do to strengthen the WHO so that it at least has a meaningful role in the global health architecture, if not the central role?
Thank you very much. I think it is a paradigm change that I do not have often with all those who are saying reform WHO. For me, it is not WHO that will be reforming the world. It is the world that reforms WHO. Just to come back to that principle, is that after COVID, after the failure of the beginning of COVID-19, many organizations that are very important, G20, G7, African Union, European Union, have made a lot of recommendations. The last time we were counting, were over 300 recommendations that were out there. And some of them has the force and the funding necessary to implement the recommendation they are making. And most of them also are contradictory. That's in this context that it is very important that the idea of negotiating for the pandemic accord become very important. Because that is the world now that is pushing for changes, and WHO is here to coordinate the world that is hungry for change. And also, when you talk about the International Health Regulation amendment that are proposed first by USA and followed also by the Federation of Russia and other countries that have proposed to change in the International Health Regulation. As a technician, most of the proposals I have read make sense and need to be done. The question is whether should we change the International Health Regulation with bilateral initiation, one country out of 194 moving for the change. Some people are asking for it. It is whether also in low and middle income countries, we have the force to talk with a bigger country that is funding a lot of important issues in our countries in order to say them no. So that's where the bilateral negotiations that are happening, on my point of view, is the way to go.
Thanks so much. Thank you.
Thank you all for that. Thank you all for that very rich discussion and candid discussion. Very much appreciated. If the speakers for Pillar 3 could now please come forward. For Pillar 3, we're going to talk about the 1 billion more people enjoying better health and well-being. This is a very important aspect of these triple billion goals, and it involves a lot of different elements to it in terms of better health and well-being. Please come forward. We will have two speakers and a moderator again. Ben McGrady is the Legal Technical Officer at WHO, and he leads WHO's work on international trade and investment disputes concerning tobacco control. Mohammed Asa is the Liaison Officer for... Mohammed Asa has fans in attendance here today. He is the Liaison Officer for Public Health Issues at the International Federation of Medical Students Associations. Welcome to all of you from IFMSA. Mohammed is in his final year as a medical student from Alexandria, Egypt, and he works to ensure healthier communities are based on health equity, not health disparities. And our moderator is Elaine Fletcher, who is the editor-in-chief at Health Policy Watch. So please, Elaine.
Hi, thank you very much. We're last but not least on the agenda. I see that when I was coming into the audience, there was a lot of people changing out of their Walk the Talk t-shirts. How many of you joined the Walk the Talk today? Great. And so you already have an understanding, perhaps a better understanding than many of your colleagues at WHO about the importance of what we call the third billion, the healthier populations as contributing to global health, because that's really the upstream prevention and what they call in the fancy language determinants of health that are outside the health sector. And so far we've been talking only about the health sector, but really so much of what we can do to promote good health has to do with issues that have to do with transport, finance, trade, and pollution, and we're gonna try and deal with these really quickly here with our panelists. So to take it away, Ben, can you tell us how this third billion is gonna play out in the WHA agenda? And I understand there's gonna be something on obesity particularly, and perhaps in that, just very quickly wrap in what's this third billion so people can understand better.
Sure, thanks very much, Elaine. So I think you've done a good job of introducing it, actually. It's the determinants of health. It's everything that is upstream. It's prevention rather than cure. So it's about addressing those determinants of health as soon as possible in order to protect the health system and in order to ensure that we have healthier populations to begin with. If we look at the COVID-19 context and we see that a very high proportion of people with severe cases of COVID had pre-existing conditions, non-communicable diseases, respiratory conditions, diabetes, cardiovascular diseases. It's about government taking early steps to prevent those conditions and ensure that the underlying health of the population is at a higher level. How's it going to play out at WHA this year? There's a huge what we call omnibus agenda item around non-communicable diseases, which is framed as a follow-up to the high-level meetings in the UN General Assembly. And I think there are about 10 different items sub-items under that agenda. It touches upon obesity, it touches upon tobacco control, harmful use of alcohol, for example, development of a new action plan on harmful use of alcohol and implementing the existing global strategy. There's an agenda item there on accelerating work to prevent obesity, an area where we've seen, I think, many countries go backwards over the last 2.5 years, partly due to sedentariness, lack of physical activity, kids not in schools, adults not out and about, traveling to their workplaces, etc. So it's a hugely important agenda, and fair to say one where we haven't in the past seen the kind of urgency in government action and attention that we've seen, say, over the last 2 years devoted to emergencies and devoted to COVID. And Dr. Tedros has been very clear, I think, in the executive board earlier this year, that now we need to see a pivot and we need to see governments focus more attention, more energy and more effort on healthier populations.
Okay, but specifically to obesity, and you've articulated very well the broader context, what can WHO do more of, and what's WHO asking its member states to do more of in the accelerator?
Sure. So, great question. I think the first point to note is that it's an accelerator. And implicit in that is that we need to accelerate the actions that we already know need to be implemented. This is not a new set of actions, but it's about acceleration. So we're going to work harder at WHO to identify those priority actions that governments should be taking. And we're committing to work harder to provide the technical assistance on the ground to help governments implement those actions, and also committing to work more with civil society to push governments to do the things that we know they need to do and that they've indicated they're willing to do in the past, and then work harder on monitoring. But I think one of the big things that's new about the accelerator is that we're calling for governments to nominate themselves as front-runner governments and to make a commitment at the Assembly and in public that they're willing to take the steps that need to be taken. Because I think in the past on obesity, we've had a lot of rhetoric. We've told governments what we think as WHO needs to be done in order to improve the healthfulness of the food supply, in order to improve food environments, in order to facilitate and support physical activity, for example. But we haven't seen sufficient implementation of those interventions. So now's the time for everyone to deliver on that.
Okay, but give me 4 examples, concrete, of what can governments do. Bike lanes, I mean, is that part of the plan, for instance? That's something I see. Walking paths. I talked to somebody doing an urban health initiative project yesterday from WHO who said that 90% of Accra streets don't have walking paths. You can't even walk around many developing cities. Are you addressing those kinds of things in your obesity planning?
Sure. So there are many things governments can do. Look at the WHO best buys on prevention and control of NCDs, and there we see some specific examples with respect to foods. For example, regulating and restricting marketing of unhealthy foods and beverages to children. It's a highly cost-effective intervention. Food labelling, including front-of-pack nutrition labelling, that gives people an indication of the healthfulness of the foods that they're consuming. Fiscal policies, like taxation of sugar-sweetened beverages, which have virtually no nutritional value and yet are highly calorie dense and consumed frequently by children. And then investing in physical activity, systems thinking around physical activity, including walking and cycling. Yeah? These types of activities that we engage in our everyday lives that don't require some special effort to go and play sport or to go to the gym, but are simple things that governments can do through urban planning, for example, through investing in infrastructure for walking and cycling rather than just motorized transport, such as cars, that need to be done to ensure that in our everyday lives, with no special effort, we can engage in physical activity.
So is investment in walking and cycling now part of the best buys?
It's not specifically part of the best buys. Yeah? There's a package of physical activity interventions through the Global Action Plan on physical activity, but it is one area that we're emphasising in our technical work with governments, certainly. But it's also fair to say that many of these issues, obesity as a whole, walking and cycling as a good one, there's issues that require systems thinking. They're not just health sector issues. They're not just issues that ministries of health have control over. And walking and cycling is a really obvious example of that, where it's infrastructure, it's transport, it's urban planning, and it's ministries of health. And ministries of health need to step up and play a greater role in advocating for these interventions that improve health, in measuring the potential health impacts and communicating those impacts, definitely. And WHO has been increasing its work on that in the past few years since the Global Action Plan on Physical Activity.
Will we ever have a healthy, best buys for healthy environments, perhaps, for healthy urban environments? That might be more specific and really put those issues out there?
It's possible. It's not on the WHO agenda this week, so we'll wait and see.
Okay.
Yeah.
Okay, I'm going to go now to Mohammed. Thank you, Mohammed, for getting your great fan club here to support these questions. I'm going to ask you about the closer? Okay. The Lancet Commission recently published a second report on pollution, 9 million deaths a year from various sources of pollution, with modern sources of pollution like traffic emissions, industry, chemicals exposures rising, and a decline, though, some hopeful decline in water and sanitation contamination, and also in household air pollution. So there's been some progress, but against that, unfortunately, there's also soaring pollution from modern sources. What would you like to see as the future medical students, WHO doing more on the pollution agenda?
Okay, thank you so much for the question. So I guess here when it comes to pollution, focusing on the environmental determinants of health in general, like this should be a priority, because when we talk about determinants of health, it shouldn't be just, for example, let's say certain risk factors that are just present in clinical medicine or something, but we need to focus on the prevention as mentioned. We should not just focus on the cure. So when we talk about health, when we talk about the future, we talk about sustainability, we need to ensure the focus on the environmental determinants of health, for example. One of the things, for example, I would say is that environment or environmental determinants or pollution or climate change, it's not present in the WHO agenda, although it's very much important and very much a priority that we should focus on. That's why IFM State delegation was here today in Walk the Talk calling for example, divestment from fossil fuels. This is something that we need to focus on. And it's not just the health sector, because yes, WHO should focus on raising the awareness about divestment from fossil fuels, but is it just the health sector that should divest from fossil fuels? No, it is also the other sectors. That's why it's also important that when we speak about health in all policies and pollution, when we speak about the effect of pollution on health, we need to make sure that all the other sectors are involved in the conversation. Because, for example, let's say the WHO, the Minister of Health would not be able to take the decision alone if the Minister of the Environment is not aligned with the same vision about what we need to do about pollution. So what I would say, what we need to see in the future when it comes to the WHO or the WHA, we need the support is to be provided for the health sector to be able to ensure that health is present in all the other policies, not just in terms of statements, not just in terms of theoretical plans, but also action, and ensuring that this is or this remains a priority. Because like when we speak about climate change or when we speak about pollution as one of the biggest, I would say, environmental determinants or environmental risk factors to health, this means it is a priority, it should be a priority, it should remain a priority until action is being done. And this would not just include the health sector, not even include the other sectors only, but would also include the public. Because any system, when we speak about health systems, or when we speak about even other systems, people should be in the center. So if we also raise the awareness about the public, for the public, about the pollution and the effect of the pollution on their own health, they would be able to lobby outside the WHO in their own countries for their own health and for more action when it comes to pollution. So, yeah.
Mohammed, when we were talking earlier, can you hear my mic? It's okay. You mentioned that also equity and poverty are part of this. Can you explain how?
Yes, exactly. Because when we speak about health, someone, for example, has a certain disease. It's not just that they got exposed to a certain, let's say, virus, if it's a communicable disease or a certain risk factor, and that's it. They may have not got enough education about something. They may have a low income status. They may be affected by their neighborhood. They may be affected by so many different other determinants that are impacting their health, but there is not much focus on. So when we get even to work on our agendas, when we get to even work on our action plans, we need to make sure that we're also working on the poverty, we're working on education, we're working on better neighborhoods, we're working on sustainable cities, we're working on all the different, I would say even the SDGs agenda. Yes, SDG number 3 is good health and well-being, but if we can see the other SDGs, they all still fit and they all still feed into the SDG number 3, good health and well-being. So it's very important for equity to be reached, to focus on these other determinants. Because if I come, for example, from a low-income country, or if I live in a certain place where I have received low income, or even if I don't have a job, I did not get an education, this is something that should not affect my basic human right of health. So if we are to implement the Declaration of Human Rights, if we are to implement the basic human rights and the basic access to health and the basic right to live a healthy life, then we should make sure that all the other determinants are part of the process and part of the plans, and even the resolutions and even the document that we get to adopt, not just in WHA, but even in other meetings, we need to make sure that social determinants of health and health equity remains an umbrella that we work on, because this is an overarching concept. Because like I can't work on a certain perspective and just leave the vulnerable communities or the marginalized populations, because this would be against the basic principles and the basic values of fairness, justice, and equality and equity for everyone. So if we are really to reach health equity, and if we're really calling for health for all, then we must ensure that social determinants of health and even environmental and commercial and all other determinants of health are part of the plan and part of the implementation process itself.
And behind the loftier ideas, we can also say with great certainty that it's usually poor neighborhoods that are more heavily exposed to urban air pollution.
Exactly.
It's poor people that are more exposed to traffic injury because
Exactly.
they're walking more and cycling more around in cities. And so there's this huge convergence between the two agendas, although we don't know if policymakers are as aware of that or if that's as much of a priority as it should be.
Like they should.
In their minds.
Definitely, yes.
Ben, just to go back one more time to you on the pollution agenda, the other item on the, as you mentioned, the NCD roadmap is on the WHA agenda for approval or endorsement by the World Health Assembly. There's been some complaints that pollution is only just sort of mentioned in passing there. It's still not a full part of the NCD agenda. It's still not the 5 by 5, as they say, that we'd hoped for. What's WHO doing to incorporate that pollution more fully into?
Great question. So, through that General Assembly process, we move from a 4 by 4 with 4 risk factors and 4 main conditions to a 5 by 5, and air pollution is recognized now as one of those major risk factors for non-communicable diseases.
Alongside, you might mention the others, alcohol,
tobacco, unhealthy diets, insufficient physical activity or inadequate physical activity. So there's that high-level recognition that as an environmental determinant of health, it's also causing a really substantial number of non-communicable diseases. To what extent is it incorporated into the NCD's work then in WHO? Well, we sit together in the Healthier Populations Division, and we work horizontally together on what are many of the policy issues that affect determinants of health. It's not necessarily incorporated into all the same technical products as the other risk factors for NCDs, but on the other hand, it also has some separate architecture through UN Environment and through multilateral environmental processes that these other risk factors for NCDs don't have. So, it's important, it's evaluated, and certainly as we move forward with reviewing and updating the best buys for NCDs, we're having discussion internally about how to cost and how to evaluate the cost effectiveness of all of the environmental interventions as well. So I think we'll see some better integration into the technical products that the WHO produces over time. But I think it's just important to recognize as well that the risk factors aren't the same. They sit differently at the national level, and we shouldn't always assume that they'll be treated in the same way by WHO or by governments as a result. So I think you're going to see over time better integration into WHO's technical work, but there are differences that also shape the different approaches of government and WHO.
But wouldn't you agree with me that as long as this sits, as you mentioned, UN Environment, yes, but as long as this is something that's handled more technically by other UN agencies, then it really won't be a central focus of the health sector. And we really won't have health ministers picking these up because we don't have a cost-benefit package for best buys like we mentioned walking and cycling or clean energy or clean transport. I mean, we have African countries importing by the tens or hundreds of thousands of used dirty diesel vehicles every year, and there's no word that's driving air pollution in megacities in Africa at least, and there's no word yet on those types of issues which are killing 7 million people, well 4.5 million I think it is from outdoor air pollution, but the total toll from air pollution is 7 million people a year. So don't we need a faster and better track for that kind of integration?
Sure, absolutely, no question about it. And we're working behind the scenes now. It's not on the agenda of WHA to update those best buys and do a new cost effectiveness analysis. Yeah, so we're working on that at the technical level at WHO. The challenge is that it's a package of interventions, and we need to evaluate individual interventions based upon their cost and then their return on investment. And so doing that in a way that helps governments prioritize a handful of things that they can do or take action on where they see a need to focus their attention on relatively few things. So I think in the air pollution context, where there are so many different interventions that governments need to take, it's a challenge. We're working on it. We can do it. We can see the need for them to focus on a handful of things, like cleaner energy generation, like better waste management, like urban planning and sort of modal shift in the transport space. Identifying the costs of those interventions in a technical sense is really challenging, and the return on investment, because they're not single interventions. It's not like a tobacco tax at a given level. So the technical analysis is much more challenging, but we're working on it.
Maybe you need to bring in some transport economists and people from other sectors, though, to help you, because that work is being done in other sectors. So maybe we need more cross-fertilization of those techniques and methods.
It's being done at the technical level, without question, but putting it in a policy package that communicates to government what it needs to do and gives the government an assessment of cost effectiveness that's accurate and that's not overgeneralized, in the sense that we're making recommendations for the whole world, is really challenging in a technical sense. You know, we had some discussion already about science versus politics, but there's also a challenge between science and communication. How can we as an organization communicate in a way that's both accurate and effective about the things that governments need to do?
Okay, let me just turn to.
Sorry, Jenny, we're going to have to.
I know I want to ask one more question though, because I think this area is the biggest, most important. This is a driver of the health emergencies agenda. I wanted to ask you about the commercial determinants of health, which you're an expert in, and you've written a book about WTO and health, which is, we've got a WTO conference coming up right after WHA. So I think this is a moment to ask you quickly, what do you see in terms, what could WTO and WHO be doing together more concretely on commercial determinants of health? And I can think of two that you've written about a bit. One that came up at a conference last week. One is ultra-processed foods. Right now, countries, or even package labeling, we've seen challenges come up in WTO when countries do take measures that are considered healthier, then they get challenged in WTO for somehow barring free trade. Another issue that I've seen recently is antibiotics sales, which it turns out are much bigger. 73% of antibiotics are being sold to the veterinary sector, not the health sector. And that may be one of the hidden factors driving AMR and also pandemics and also unhealthy diets, because it's feeding our meat, it's feeding our thirst for overconsumption of meat. So, you know, how can we tackle these kinds of issues together with WTO?
Yeah, hugely challenging. So we on processed foods, very briefly, I think we need to learn ultra-processed foods. We need to learn from the tobacco experience and the intersection of trade and health there. WHO worked very effectively with WTO to raise awareness about governments' legal obligations and the regulatory space that they had to implement a variety of very effective and very hard-hitting interventions in the tobacco space, including tobacco plain packaging. We have a similar model in the context of obesity prevention and food regulation, and that's a model that we pursue and we need to obviously do more of. On antimicrobial resistance, I think we're at a point in the trade discussion now where there are bigger forces shaping international trade. You know, the conflict, the war in Russia, between Russia and Ukraine is obviously one of them. Broader challenges at the WTO to dispute settlement. We're at an inflection point where we see the extent to which governments are prepared to maintain a rules-based international system as compared to a power-based system where governments are able to use trade to coerce one another to change their policies. And that's on environmental issues, that's on antimicrobial resistance. It's a wait-and-see space, and one where there's high politics, and I'm very hesitant to sort of comment on which direction governments should or shouldn't go. But I think in the next 12 months, we're going to see a lot of proposals for dramatic change of the international trade architecture. And it'll be interesting to see to what extent health and environmental protection can really be at the center of that, instead of a sort of neoliberal vision of economies without government intervention. So fingers crossed. Yeah.
We're beginning to see maybe some signs of that with the fisheries negotiations, I think, which is fisheries being a really important source of healthy protein for billions of people around the world. Mohammed, just to wrap up on a lot of these issues, education of the next generation and of future doctors and also veterinarians, perhaps, pharmacists, is really critical. Can you say anything about that space before I'm supposed?
Exactly. So yeah, like I totally echo what has been mentioned, and this is why we need to follow, and we are actually trying to do this following One Health approach when we get to tackle the different public health issues. And this is what actually also IFMSA is doing with the veterinary students, pharmaceutical students. We're doing things together in order to ensure an interdisciplinary collaboration in order to tackle the different public health issues. Because like everything is interconnected, all the disciplines are interconnected together, and if we're calling the other sectors, when I mentioned health and all policies, if we're calling the other sectors to collaborate together, this is what we need to do as future healthcare professionals, that we need to work together in order to make sure that, for example, something like antimicrobial resistance or other diseases are not, or at least are being addressed from very early measures from our side as students at the moment, in order to make sure that we are like doing the most that we can do through our interprofessional collaboration, through including these issues into our medical education. We're very much advocating for the inclusion of the different public health issues, AMR, even we're working now, climate change, adolescent health, including all of this into the medical curriculum, because a future healthcare professional should not just focus on the clinical part or the diagnosis part or the treatment part. We need to focus also on the different levels of the prevention part. In order to do this, we need to understand the scope of work, the scope of everything that's happening around us, and that's why we need to include these into our medical curricula at the moment. We're advocating for this, we're trying to do this. IFMSA is also part of the WHO Youth Council, trying to engage and raise the voice about this. And we're also trying to do the work in order to practice what we preach and lead by example in this as well, so yeah.
Yeah, I'd call the IFSMA the Greta Thunberg of the health sector. So congratulations on your work, which is very persistent, and you really are the future voice for policymakers who need to look towards the younger generation in terms of what we need to do next. I'm told that we're wrapping up here.
Thank you very much. Thank you very much. That was very interesting and enlightening discussion of determinants of health that are so important. We're now going to turn to what is called Pillar 4, and if the speakers could please come forward for that. It's WHO External Relations and Governance, and it's really a key aspect of the entire effectiveness of the World Health Organization. And what we'll do now is to have a fireside chat without the fire. This will feature Magda Roballo. She's the Global Managing Director for Women in Global Health. She also is a member of the WHO Global Expert Panel on Health Emergency and Disaster Risk Management, and has other esteemed roles that you can find on the Graduate Institute's website. With her will be my colleague from the United Nations Foundation, Laurie Sloat. Laurie is the Senior Director for Global Health at the UN Foundation, and in the past has worked at Gavi, the Vaccine Alliance, and at the World Health Organization. Let me turn it over to Laurie, please.
Guess we got cut out. Oh, there we go. Okay, I know we're a little bit over time, but you know, contrary to the last panel, they thought they were last but not least, but we are. So it's a really important discussion because I think this is a bit the forgotten pillar, right? So it's about WHO external relations and governance, and that's what we're here for this week at the World Health Assembly, where member states are the ones who get to influence sort of the work of the WHO, but also the non-state actors and the dialogues that'll be happening. So really happy to have you here with us. Thank you, Magda. True honor. So one of the things, I mean, in the Director General's first tenure, there's been a lot of changes and transformation. There's a new WHO scientific officer, right? So that's new. There's been a push for country resources, the resources to go more to countries and to sort of push on mobility of staff to countries, but also a lot of work on more transparency with the results and the financing of WHO, which is really important. And I hope a lot of you have had a chance to look at the results report from the program budget for 2021, and maybe we'll go into that a little bit. But what I'd like to ask Magda is, you know, in Pillar 4 in the WHO agenda, there's really a priority that's been set on mainstreaming gender, human rights, and equity into its program. So how do you think the organization is doing on this front? And do you think there's anything in terms of that the pandemic has impacted that in its ability to sort of mainstream? So over to you.
Thank you. Really a pleasure to be here, and I hope next year we'll have more time and will not be last. Governance issues, equity issues, gender issues are really important issues, and we cannot have a governance structure that works for the entire world, for all of us. We cannot achieve justice, we cannot achieve equity, we cannot achieve human rights if we leave gender issues behind. There was a lot of discussions before around the workforce and how do we finance the workforce that we need. 70% of the workforce are women. And next time, I would like to see us discussing financing for health workforce and how do we make sure that women get safe, decent, free of violence, free of harassment, working conditions, so that we can actually achieve the progress that we want to see within the health system. I'll soon come to WHO. So we cannot achieve progress and the outcomes that we are aiming for if we leave women behind. If women are 70% of the health workforce, how come the governance structures don't include women? It is like you are shaving my head without me. And that cannot be. So we really need to make sure that decision-making, leadership positions in WHO across the board, women are taken into consideration. They have the expertise, they have the talent, they have all that matters that is needed, the skills, and still we do see directorship, senior directorship, boards and committees where women are lacking. What we are saying, no more governance structures like that. It's a failure of governance if you leave out majority of your workforce, majority of your population. I think we do agree on this one, right? So going back to...
You give a lot of support for that.
Going back to WHO's progress in terms of their governance reforms, I think there is a lot that can be said about the WHO reforms, which is something that has been going on, and I think it should continue, but it should get to a point where we actually feel that there is a change within WHO. The global health architecture cannot be revitalized if the WHO reform doesn't get to the point where it needs to be. It is good to see these statistics that are published just before the WHO. I think there is some progress, but we are not at the 50% that we are demanding. So at least 50% of women in senior leadership positions, all the way down to the programs, all the way down to the regional offices, all the way down to the country offices, and asking member states that they also do the same. We have seen before the pandemic that the delegations are at least 25% of delegations being led by women. During the at the executive board before the pandemic, we had around 30% of delegations headed by women. Come the pandemic, it dropped by 6% of delegations led by women. That's not acceptable. We are going backwards, and the pandemic actually brought to our eyes all the deep, broad, and profound inequities that exist within our societies. And number one inequity is actually women being left behind. Majority of the population around the world and women are left behind. During the pandemic, where actually 90% of the frontline health workers were women providing the services. From developing world, we have seen the lack of supplies, lack of PPE, lack of masks. Most of the healthcare workers are women, and they were working for COVID, against COVID, supporting our collective health without the equipment that they needed to protect themselves. Women are overworked, mentally distressed. In some countries, they are threatening to leave the profession because they don't feel valued. And these are some of the issues that we are demanding, that in reforming, it's not just about which kinds of structure do we put in place, who sits in those structures, and what kind of work conditions do we provide to the professionals.
Could not agree more. And I think something important to highlight is when you look at the WHO results report, it actually does have there in the indicators in that fourth area, the gender dimension in some of the way that they look at, as you were saying, the senior leadership, right? So it's there. I just quickly glanced at it this morning. Didn't know I was going to be moderating this panel today. So when I looked at it, in the Office of Wipro, for example, they say that ratio is now 38%. I might have that wrong. It might be EMRO. But the point is, it's there to look at, but it's on us to keep pushing for it. So I think, on the one hand, it's good news that it's actually being reflected in some of these indicators because it's very important, and we can see the progress over time. But obviously, it's not enough because look where we are in so many aspects. But I think it's on us to all keep pushing that and reflecting on the progress over the next biennium. So thanks for that.
I think the progress is not only insufficient, but it's very volatile as well. Over time, you can quickly see things moving backwards, and we really need to build the pipeline where women progressively get into those positions of leadership. It's not because the women are not there, but we need to pay more attention to the gender dimension within our global health architecture. Otherwise, the reforms will go on without addressing one of the fundamental issues around gender equity. We can't achieve social equity and equity around the world if we are not able to walk the talk. This is the real walk the talk. If you if you can't address the glaring inequity that you have within your health systems, that is, women are majority of the health workforce, but not represented in your decision-making structures. How can you talk about achieving global equity across countries, within countries, and then fixing those problems that we are seeing?
Couldn't agree more. So I'm going to move now to some policies that WHO has been working on in terms of its policies to improve how it handles the sexual exploitation. So I don't know if you had some comments on this, and how do you think it's going? And where has there been success in that area? But then where is there more room for improvement along those lines as well?
I think the drama around sexual exploitation, abuse, and harassment is one of those that we need to collectively work together on eliminating. When we say eliminating, we know we cannot eradicate it, but at least try to get to a point where staff that are hired to protect populations against diseases, abuse them because they have power, economic, political, and otherwise, and leave children behind. There is no justice for the victims, and that's totally unfair. The DRC Ebola case where WHO staff and consultants were involved brought to light something that happens every single day in humanitarian emergency situations, but also in development contexts. There are other cases in other countries where this is happening. I think WHO took a step in terms of quickly developing a response plan, management response plan to address the situation. Last month, we had a town hall meeting with DG Dr. Tedros, where they presented the progress they have made so far and their commitment to address the issues and prevent and protect the populations that are at risk of becoming victims of this situation. They established a department for preventing and sexual exploitation, abuse, and harassment with an interim director. We hope that there will be an appointment so that the department can be staffed and work on these issues. And we continue to demand that the WHO pay attention to the issue of justice for the victims. There are over 20 babies born out of that scandalous situation. And what we are demanding is that WHO and other international organizations work together and put in place systems to orient staff, train staff, and mechanisms to prevent this from happening. Member states also have a role to play, because very often when these cases are come to light, you see a disconnect between the outcomes and recommendations from the report and action from the Minister of Justice and the structures in the country where these victims are living, which needs to be taken on board by the own government. So this is an issue we need to continue working on to make sure that the policies, the right policies and the right action are in place to prevent sexual exploitation, abuse, and harassment in humanitarian emergency settings, but also across the development world.
So you've mentioned a few things in terms of the management report that came out, the town hall and so on, and also the recommendations to the government. So do you feel confident because of these mechanisms that still maybe need to be established, but that they will be, because there's, sort of the intent there? Was it the right approach? Is it enough? I mean, what do you want to see?
Not at all. Not at all. I'm not confident. I don't think it's enough. And if we don't continue following up and demanding that this is done, it's going to be like many other things. So you turn your back, and then there is another priority, there is another emergency, and then you don't see a follow-up or even growing an active response from the department. So it's too early for us to say that we are confident. We need to continue putting pressure, following up, and demanding that action is taken until the managed response and management plan is implemented, but also that we see justice for the victims. That's very important. For the survivors, that's very important.
Okay, so it's there, but we got to keep pushing, as always, on these issues. So thank you for that. And I'm just going to close out the last question around the financing. So there's a lot of discussion that'll happen this week on sort of the broken financing of WHO and how it's funded in terms of its flexibility in funding. So as a lot of us know and have been reading, that the WHO's financing is based 20%. It's actually under 20%, comes from what they call the assessment members. It's essentially the member states' dues to the organizations, and that's the ultimate flexible funding, but it's only 20%. So given if it passes, that they actually increase the amount to say 50% of the assessed money coming into assessed contributions, how would that affect some of the reforms that you would like to see take place around some of the policies that you've mentioned? If there's more financing, how could that help the organization, some of the themes you've brought up today?
We really hope that the increase in assessed contributions will be approved, and WHO will get better from the chronic financial situation they have been battling over many years. But that's not enough. More money is not enough. You really need to know where your priorities are and how you're going to invest that money. There has never been so much money in the global health sector over the past 10 to 20 years with the Gavis, the global funds, and all the initiatives. Yet, look at the outcomes, very poor, because we have inefficiencies, because we don't invest on the right priorities, because we compete. There is a lot of competition at global, regional, and country level. At the end of the day, the population remains unprotected, ill health, and we have outbreaks that become pandemics because of the poor investment in the right priorities. So it's a good step forward to have member states increasing assessed contributions. The next step will be, what are the priorities where WHO is going to invest the increased amount, increased money, the financing that they are going to have? Are they going to address gender equity so that we have a balanced WHO to be able to look into the challenges in health with different eyes, with gender lenses? If you don't address the gender equity, you cannot address the other inequities that affect the health sector. So wait to see, but we'll need to be held them accountable. There has to be transparency in allocating these resources, and then we need to hold WHO accountable.
Okay, that's great. Thanks. So I think we'll leave it there, and just really want to encourage everybody to take a look at the results report. I also think there's an investment case that's coming out tomorrow for the organization. But this is just a reporting. There's a lot of progress that needs to be made, and it's champions like yourself, Magda, and those of us here in the room who are going to help sort of push these agendas forward, make sure gender's there, make sure the right policies are in place, that the money gets allocated to where it is. But it does take us all. So I think that's a good way to end the dialogue today. And thank you all very much for joining. Thank you, Magda.
Thank you very much. Thank you very much for that very good discussion of the gender equity issues, the sexual exploitation concerns, and of course the need for sustainable financing for the World Health Organization. At this point, I would just like to briefly say, on the part of the UN Foundation, how happy we are that all of you were able to attend here in person, and the many of you online. Thanks to all of our speakers. I also want to thank my colleague Lori Sloat, who substituted at the last minute for our Vice President for Global Health, Kate Dodson, whose flight was delayed here. But from the perspective of the UN Foundation, I'd particularly like to thank Dr. Swery Moon and her staff, because they have put this on here as the host here at the Graduate Institute. There's a lot of work that goes into this with the various speakers, et cetera, and we really appreciate the collaboration we've had since 2015. So I want to sincerely thank you for that, and as well as all of your staff. And now let me turn it over to Swery for last comments. Thank you.
Thank you so much, John, and I'd really like to echo the thanks to indeed all of our really insightful and fantastic speakers and moderators, to all of you as participants. We had wanted to have more time for Q&A, and I miss in the Zoom the little chat where you can actually constantly be communicating with other members of the meeting and commenting on things. The closest thing we have to approximate that is the reception, where we hope that all of you can join us, at least have a drink and a bite to eat, and approach the speakers, and don't be shy, and the moderators and each other, to take advantage of these two rare moments when we are able to be in person together. Before giving two last sort of words of thanks, what I wanted to do was maybe just sum up at least one of my takeaways, and I'll just do one because I know I'm standing between you and lunch. My key takeaway from all of these discussions is that protecting public health, individual health, and trying to make progress on health equity is really hard work. It takes effort across such a huge range of issues that we've only managed to touch on today, really just scratching the surface. And we, I think what we tried to do indeed was to take a snapshot, take sort of a 10,000-foot view of the wide range of issues on the agenda of the Assembly this week. Of course, there are technical aspects, there are scientific aspects to these problems, but also often very much political dimensions, as I think many of the speakers spoke about today. And when I think about the Assembly, what is the Assembly really? It's the week when governance happens, it's a week for politics, it's a week for advocacy, it's a week for debate and dialogue. And so we wish all of you success as you engage in these efforts over the coming week. For me, one of the key takeaways is how beneficial it has been to hear from this wide range of voices, looking at from local, national, and global perspectives on a wide range of problems. But I think we still need actually wider engagement, both within the health community in global level debates and outside the health community, which is something that we heard quite a lot from the environment, from transport, from tax policy, trade, et cetera. We need to be able to find ways to engage outside the health community in order to adequately protect health. So I hope that all of you will help us to engage in these wider discussions, bring in new voices to really open up global health governance processes, and that the Assembly this week, despite the restrictions on in-person participation, we do hope that the Assembly this week can really open up global health governance processes to everyone. So with that, let me thank very much my colleagues at UNF, indeed, for the strong partnership over the last 8 years. It's been a pleasure and a great learning experience for me to learn from how you all have done this for the past 8 years. And last but not least, let me thank my colleagues at the GHC. It's a very long list at the Global Health Center, the students, the staff, and also the events team, including our technicians at the back of the room, whom you often don't see or hear. It takes a really, really big team to bring everyone together, and really please join me in giving all of our colleagues a big, warm thanks before we have lunch. With that, bon appetit, and see you upstairs.